Harsh Chaturvedi, and thank you, Mr. Kiran Das, and thank you, Pulse, for inviting me to talk on today's topic. My topic, can you see my slide?
Uh, yes, you'll have to go to presentation mode.
Yeah, yeah.
Yeah.
This is, can you see the slide?
You need to get to the bottom, sir, and there will be a presentation mode. If not, then there is a reading
Yeah.
mode where you see an open book. Yes,
No, can you
yes,
see?
yes, yes.
Yeah. So thank you, Pulse, Dr. Chaturvedi and Kiran for inviting me to talk on this webinar, which Pulse is supporting today. I've been asked to talk about a bird's eye view of nutrition into intensive care unit. So most important, we know that nutrition is a very important aspect of all patients who are admitted in the ICU and all critically ill patients. Be it like almost if you really analyze them, 50% of those patients are admitted into the intensive care unit. On assessment, you find that they're in a malnourished state. They need nutrition because if you don't feed these patients actively, very aggressively, there is going to be an increase in the morbidity, mortality. There will be increased length of hospital stay. There will also be increased length of stay in ICU. And more about that, some of the patients, there can also be increased length of stay, or the duration of mechanical ventilation can also increase. Nutrition therapy is equally important as much as all critically ill patients. We know that nowadays we follow guidelines. We know that we have got guidelines which are available for management of septic shock. Give antibiotics within the first 1 hour. We know that refractory shock, you add steroids. We know that for thrombolysis, we follow a protocol for AMI or for stroke. We know that for renal replacement therapy, we have a protocol. For ventilation, we have a protocol. So everything is running protocolized. Similarly, then all these prescriptions we plan. We do plan the antibiotic prescription. So equally important is planning up of this medical nutrition therapy or the nutrition prescription for our patient. And this has to be personalized as much as what we see as far as personalized antibiotics, personalized ventilation, personalized dialysis prescriptions. And therefore, assessment of nutrition status is very important. It has to be tailor-made. A nutrition plan needs to be taken into consideration. And of course, a counseling of the patients and the relatives need to be done along with the lifestyle changes. Now, this medical nutrition therapy is specifically is to optimize the patient's health by providing adequate amount of nutrition and calories. And these have been recommended by the European Society of Parenteral Nutrition as well as by the American Society. Now, the trajectory of the patients who are in the ICUs, we don't just have nutrition therapy, which is important only for ICU. Mind you, you need to give patient nutrition therapy even for patients who are admitted into the ward patients, because there has been no difference in the outcomes or the length of hospital stay. You have a simple patient who is admitted into with a fracture neck femur in the ward. He's just been operated, but if you don't give him the adequate amount of calories and the proteins to do the physiotherapy, that is not going to be possible for him to have the energy. Otherwise, if you don't give him proteins and calories to do the physiotherapy and the recuperation of physiotherapy, what is going to be required for him. So nutrition therapy is not only important in the ICU, but you should also plan your nutrition prescription for all patients who are admitted into the wards. Right, we have got a pre-admission where a critically ill patient comes up. There has been a pneumonia or ulcerative colitis with sepsis, or it could be a ARDS with sepsis, gets admitted to the ICU. There will be mechanical ventilation, which can be required for the patients, be it invasive, non-invasive. There will be acute phase reactants because of the inflammatory markers, pneumonia, sepsis, whatever it is, UTI precipitating a sepsis. And these patients spend a lot of time in the ICU, be it for a short week or sometimes these patients get chronically admitted and they spend more duration into the intensive care units. And at one moment of time, they have got a stability where you plan to shift them to the ward. And once they have been actively mobiles, you also need to have a discharge plan which is ready. So the nutrition prescription really needs to be optimized right from admission to the ICUs to the shift out at the time of shift out into the ward, and even when the patient is going to go home. If the patient is going to go home, you need to plan a long-term recovery of the patients, or you need to require a short-term recovery for till he attains back his regular intake. A long-term patients, for example, a Crohn's disease, ulcerative colitis, or patients with malignancies, they are always in a hyper